Hi, everybody. Hi, welcome, everyone. Hi, thanks, everybody, for joining us today. My name is Maya. I'm a co-host here today. This is the fourth event in the Recovery Science Series webinars hosted through the Recovery Research Institute at the Massachusetts General Hospital. This is an Opioid Response Network sponsored event through the American Academy of Addiction Psychiatry. Today's webinar topic is using recovery science to dismantle racial health inequities in opioid use disorder, presented by Dr. Corrie Vilsaint. Again, my name is Maya, and I am a clinical research coordinator at the Recovery Research Institute. I am joined by Chris Raton, the health communications coordinator at the RI. We are the co-hosts here today, so feel free to send us a chat if you have any questions. We're just going to wait until 3:02 to officially get started to allow everyone to kind of trickle in. But just to give everybody a rundown on what they can expect today, we are going to get started with a brief introduction to the Opioid Response Network and the Recovery Science Series webinars. That will be followed by a few polling questions, and then I will turn it over to Dr. John Kelly to introduce our presenter today, Dr. Corrie Vilsaint. So to everyone joining us, hello, welcome. This is the fourth event in the Recovery Science webinar series, sponsored by the Opioid Response Network. My name's Maya, and I'm a staff member at the Recovery Research Institute. So we are going to go ahead and get started just with a brief introduction to the Opioid Response Network and the webinar series. So welcome, everybody. I'm going to get started by just playing a quick video to give an overview of the Opioid Response Network. This video can be found on the Opioid Response Network website, and the URL is also displayed below the video. So I'm going to go ahead and play it.
Communities across the nation are mobilizing to address opioid and stimulant use and the overdose crisis. You can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the opioidresponsenetwork.org to learn more and to submit a request for support. The Opioid Response Network, funded by the Substance Abuse and Mental Health Services Administration.
Okay. Yeah, so that's just kind of a brief introduction to some of the things that the Opioid Response Network can do. As mentioned in the video, you can find out more on their website.
Communities across.
And just really briefly, these are some of our past webinars. The recordings and the slides can be accessed on the Recovery Answers website and the Opioid Response Network project section. The URL is right under the slides there, and I can also drop the link to the chat to where you can find, again, recordings to some of our previous events. And keep an eye out for our next event, which will be in April of 2022, April 27th. Dr. Lauren Hoffman, another member of the RRI team, will be presenting on opioid use recovery. And here is today's event. So again, today's event is titled Using Recovery Science to Dismantle Racial Health Inequities in Opioid Use Disorder, presented by Dr. Corrie Vilsaint. And before I turn it over to Dr. Kelly to introduce Dr. Vilsaint, I just want to run a quick poll for our attendees today. So please take a moment to fill out this poll if you'd like. There are 3 questions here. It's optional, but we'd like to hear from you to first get a sense of who is in attendance today in terms of educational and professional background. And then we also have a content-based question from Dr. Vilsaint. So I'll go ahead and leave this poll up for about a minute just to let people read it and answer, and then I will turn it over to Dr. Kelly. Great, yeah, thank you everybody for answering. Yep, getting some great participation. Thank you everybody. All right, so I'm gonna go ahead and end the poll and I will share the results. Okay, great. Thank you everybody. So without further ado, I will go ahead and turn it over to Dr. Kelly, who will introduce Dr. Vilsaint.
Maya, was there a content question too?
Yes, there was a content question as part of the original poll, yeah.
Great, fantastic. Thank you. Well, I'm Dr. John Kelly. Welcome everybody. Thank you so much for coming, taking time to attend today. I know it's going to be worth your while. We've got a fantastic speaker. We are, the Recovery Research Institute is one of 40 partners in the Opioid Response Network. We're very honored to be a partner and participate in expanding the knowledge infrastructure around clinicians and clinical programs around the country regarding the treatment of opioid and substance use disorders and recovery support services. In regard to that, we're so delighted to have our own Dr. Corrie Vilsaint present today. She's a national leader in this area. She's a principal investigator and research scientist here at the Recovery Research Institute and Center for Addiction Medicine at Massachusetts General Hospital and Harvard Medical School. As a community psychologist, Corrie has focused her efforts on reducing discrimination among individuals in recovery from an alcohol or other drug use disorder, on building recovery capital and resources for people entering recovery, and including the effectiveness of recovery housing. And what she's going to talk about today also, which is racial health equity, and where she's really having a national and international impact. So really delighted that Dr. Vilsaint is here with us today. And Corrie, over to you.
Great, thank you. Okay, I'm just going to jump right in and start sharing my slides so we can get started. Okay, there we go. So we're going to jump right on into recovery science, how to use it to dismantle racial health inequities in opioid use disorder. But first, I'd like to start with a bit of an overview so you know what to expect. I like to give everybody a quick lesson on what I call racial literacy. Then we'll give you the backdrop on epidemiology, move into course in illness and recovery, and then the actionable strategy for recovery transformation in Black communities. I always say you got to start from the beginning though. You have to know how we got here. So it was about nearly 20 years ago. There was a landmark report commissioned by Congress, prepared by the Institute of Medicine. It found that there were striking disparities in the burden of illness experienced by Black Americans. This put health equity on the national stage and crystallized the need for rigorous scientific approaches to minority health and health disparities, given the implications on patient safety, quality improvement. Our field is no exception in recovery from alcohol and other drugs. We have 40 years of evidence that have shown that Black Americans suffer disproportionate burden of health and social consequences, despite having a often lower and sometimes equivalent prevalence of substance use and substance use disorders. Some of our most important leaders have cited the social and moral unacceptability of health disparities by race. So let's do some scientific housekeeping so you're better positioned to be a part of what I'm going to show you. So scientifically speaking, race, this is a socially derived construct. It should not be interpreted as a proxy for ancestry, biology, genetics, or class, which we used to use it as for quite often. This is a distinct construct akin to a caste system. Health inequities exist because of disproportionate exposure to risk and protective factors. You may now hear about this, sometimes cast as the social determinants of health. And so we have just a few of the factors that we know here disproportionately affect individuals who identify as Black, broadly speaking. For example, we know that in this country, families who identify as white with children, for every $1 they have, African Americans have 1 cent for their family. So we have extreme wealth distributions, which are fundamentally a root cause of everything that we see. So what are the analytical implications then of when we use race in science? Race is a variable that we really consider there. We don't have a cause of. We don't have variables in our database that we're searching for a cause of race necessarily. What this means is technically we don't have confounders of this variable, because we identify confounders based upon something that's going to cause both your independent and your dependent variables at the same time. And so this means that, you know, these gross associations that we start with at the beginning, they're real. So another way of talking about this, explaining is that, you know, race can cause your health status. However, having an opioid use disorder cannot make you Black, right? Race can cause your class status. However, being poor cannot make you Black. So there's a directionality of things that you have to keep in mind when you're interpreting your science, your studies, and things that people are presenting to you regarding race and the association with other things. So let's just talk about the backdrop of epidemiology and what's going on here. You know, when we think about what's driving the current crisis, it was around 2013. It was focused more on prescription opioids because it was strongly correlated with changes in prescribing practices, which was well documented in the press, lawsuits, pharmaceutical companies. But when you think about what's happening now and the shift in dynamics with the rising deaths due to heroin and then mostly deaths due to illicitly manufactured synthetic fentanyl, which you see here marked by the rising brown line as dominating these overdose deaths. The bigger picture here really is polysubstance use crisis due to unpredictable drug supply. Increasingly, the supply is unregulated, unpredictable, and someone who's using opioids has no idea what they're getting. In addition, we're seeing rising rates of cocaine and psychostimulant-related death as well. So when we look at treatment utilization, going back to 2003, 2013, the most notable trend that you see here is that white individuals were utilizing treatment at a linear rate compared to Black individuals. You know, so why is this? Well, individuals who identify as white were more likely to have started on prescription pain medicines. They had to switch to heroin and even potentially injection drug use when their supply was compromised. So experiencing those transitions forced them into treatment as observed here. So that switch to heroin following prescription pills is associated with an increase in accessing treatment. Individuals that identify as Black are less likely to have started on prescription pills. And therefore, they're not experiencing the changes that white individuals on average were experiencing that push them into treatment that we see during this time. Now, when we look at the age at which white versus Black individuals use treatment, you'll see that compared to white patients, which are displayed on the left, men are on the top, Black patients are entering treatment at a later age. So white patients were entering treatment for heroin around age 25, 29. while Black patients were entering around age 45 to 49. So this means that patients that identified as Black had delayed treatment initiation by around 20 years later. And as you know, that early treatment initiation is associated with a better prognosis. So Black patients are entering treatment with a more chronic course of illness, which is in part explained by delayed treatment utilization. Now, this is a nice graph that shows it specifically for heroin treatment. There have been other studies that have found this. In fact, it was my co-author, my colleague Lauren Hoffman, who co-authored a study that showed that this was a trend 4 to 5 years. Black patients were 4 to 5 years delayed in seeking treatment for a number of primary substances. And that study ended up getting attention and cited in the Office of National Drug Control report as they laid out their policy plans for the administration. Now, okay, so here, when you look at rates of overdose death among people age 55 years and older, and then stratify it by race and sex, it is incredibly revealing as to who this epidemic had a devastating impact on. Black males over the age of 55, as indicated by this skyrocketing blue line. This is a cohort who we consider who may have made it through the previous heroin epidemic, meaning before the prescription pills were so widely available. So perhaps maybe they've always had a history of injection drug use. They could have been being maintained on methadone perhaps, but the changing drug supply, meaning fentanyl, has caused their death. So what else do we know about how to characterize this population besides demographic and besides the demographic background, like age 55 and older and African American? There were some key findings that came out in the state of Massachusetts. And here we find that people who are at the highest risk of death are people who are unhoused. They have an opioid use disorder rate. They have a death rate, I'm sorry, of 16 to 30 times higher. And then for those who were incarcerated, their overdose rate was 120 times higher. You know, and the thing that we keep in mind here is that, you know, treatment models are not always designed with these people in mind. So there can be a discordance between who's at the highest risk of dying and our treatment systems or our care systems. But this is an area that recovery support services can help fill this gap, which we'll talk about a little bit later. But let's bring things up to speed in terms of the timeline regarding what happened during the pandemic. So Black overdose mortality overtook that of white individuals in 2020 for the first time since 1999. Currently, and this goes back to your polling question, American Indians and Alaska Natives, as indicated by the purple line here, are experiencing the highest rate of overdose mortality, which is 31% higher than individuals who identify as white. In our poll in the audience, there was 13% of the audience identified American Indian as having the highest overdose rates, mortality rates. 50% endorsed white, which is consistent with what the way things used to be. Actually, this is the most recent data that's teaching us here. So basically, you know, since COVID, things got worse. It should come to no surprise when you think about what drives drug use disorders, isolation, fear, trauma, despair, lack of economic opportunity. In addition, you know, the global lockdown made it harder for people to access treatment, harm reduction services, and the recovery support services. So we have to think about the toll that this has taken on people who use drugs or have drug use disorders or accessing or trying to access recovery support services. Okay, so I'm just going to go into what we know about course of illness and recovery in terms of racial health equity, though. So there's been a considerable body of evidence that's shown that Black individuals progress from the initiation of use to the onset of the disorder faster. This is an effect in the literature known as telescoping. Black individuals have a later age of onset for substance use disorders in their mid-20s to others who appear to onset in their late teens. And that's been replicated numerous times as well. When it comes to the most persistent substance use disorders, we've identified that there's a disparity when it comes to Black individuals with less than a high school education are 2 times as likely to have that persistent substance use disorder compared to their white counterparts who also have the equivalent of a high school education. Now, this finding came from medical claims data in the state of Florida. They found that Black patients were less likely to receive opioid use disorder medication, was one finding. And the second finding was that it was more likely to be a secondary diagnosis. That means this is something that we can keep an eye out for. Maybe this is related to why they are less likely to receive the medication, which we know is a life-saving frontline treatment. There was research coming out around 2015, 2016, telling us that the dominant use of buprenorphine for white patients occurred at the exact same time that overdose rates just started rising fastest for Blacks as opposed to whites. And national data that was published in JAMA Psychiatry showed us that Black patients were 75% less likely to receive buprenorphine prescription at their visit compared to white patients. So what do we know about, in this study, this came out of New York and is a pretty fair description of what we understand about the way treatment is rolled out right now for opioid use disorder. It's a 2-tiered system. Buprenorphine is more so for individuals who are white and high income, while methadone is more for people of color and low income. So when we take a look, moving into getting closer to remission, we know that there was a national study. This was using the NESARC data. It found that Black individuals were less likely to remit compared to individuals who identified as white. However, once they entered the variable marriage into the equation, the racial disparity disappeared. And so the race coefficient's no longer significant. They interpret this as a form of social support. And it is true that Black individuals are less likely to be married. And in this case, they were able to count for the outcome using that. But nonetheless, it's still a disparity in course of illness and recovery. Now, a study that we did at the Recovery Research Institute, this was inclusive of many substances, found that Black individuals on average had to make 3 serious recovery attempts compared to other groups that made about 2 on average when we looked at a recovery sample. Okay, and so let's talk about some of the actionable strategies that have been identified for recovery transformation in Black communities. And I certainly can't talk about all Black communities, but I'm telling you some of the things that has been highlighted to me when I work in Black communities and the stuff that they want. And, some of the good news is on this is you don't have to start from the beginning. We have evidence-based services that can do these things that you can pick and choose from. I feel like sometimes it's just a matter of pulling them together in the right places for the right communities. So the first thing that we have to learn is that you have to go into Black communities. Now, there is you have to understand before going in there. We talk about understanding culture and background. There's a high level of medical mistrust towards medical professionals. In fact, there was a study from the Recovery Research Institute found that Black individuals had more negative attitudes towards agonist medicines like methadone. But these things are loosely connected to a long history of medical mistreatment of Blacks. There have been gruesome experiments that have been documented at the hands of scientists and the federal government. There was forced sterilization of Black women. And then there was the infamous Tuskegee syphilis study that withheld treatment from hundreds of Black men for decades, so doctors could track untreated course of illness. I remember watching Bill Clinton on TV still apologizing to those individuals that were put through that. That was a cohort of Black men who were mostly illiterate. And it's those things that gave rise to our protection of vulnerable populations in research. To this day, a recent study found in their sample, about half of medical students and residents held one or more false beliefs about biological differences, like Black patients having higher pain tolerance. And so the idea here is that leveraging some peer recovery support services as opposed to professional or clinicians alone can help to navigate communities that have higher levels of medical mistrust. So I'll give you one example. Recovery support services have been talked about in this series. So I'm going to show you one example of something that's based in science, it's informed, and using recovery housing. You know, recovery housing for opioid use disorder. This is going to be a sample that's mostly African Americans. In this case, they were all leaving detoxification. From a scientific perspective, that's incredibly valuable because it sets a baseline for things that might be going on that you wouldn't otherwise know. So it's very rare to get a sample like that. And the first study I'll show you came from a tightly controlled, randomized controlled trial. And the other one is a very good quasi-experimental design on recovery housing for opioid use disorder. So the first study here, which was that RCT that was published in 2012, you actually have a 3-arm clinical trial here where the first group was just assigned to usual care, meaning you give them following detoxification, they have a list of referrals of community resources and treatment providers that they can go link to on their own. The second condition is recovery housing. Now this was abstinent contingent recovery housing. So they did receive drug tests for opioids and cocaine every 2 weeks, and their housing was in place as long as the tests were negative. There was a way for individuals who had a positive test to make their way back into housing eventually as well. And then the last condition where they coupled the recovery housing with reinforcement-based treatment, while the treatment period lasted only 12 weeks. You can see here that when you look at the 6-month follow-ups regarding their abstinence rates, 13% were abstinent at 6 months who had the usual care referrals. For the housing alone condition, it was 37% were abstinent at 6 months, and then 50% when they combined the treatment with the housing. There weren't employment outcomes reported in that particular paper. And then in 2017, the same authors were trying to use this research base to isolate the effects of the treatment that was administered. And so there was no recovery housing alone condition here, but rather they compared treatment in one condition to treatment plus recovery housing in the second condition. And what they found at the first pass of the data, they actually found no differences in these two groups. And the reason for that is because the people who were in the treatment alone group, a significant proportion of them actually paid for their own recovery housing on their own outside of the study. So that messes up your design. So post hoc analysis, they decided the best they could do was look at everybody who actually accessed recovery housing and compare them to the people who didn't access recovery housing. People who access recovery housing were 4 times as likely to be abstinent at follow-up. So what do we know about how these things actually confer benefit? It often, greater time and retention is the most common finding. Getting them to really stay in that house for at least 6 months is kind of the goal here. And this study that looked at how these how this process happened in recovery. A sample of people who were in recovery housing found it was linked to increases meaningful activities, then followed by the reduction in barriers to recovery and unmet needs. And in turn, that was linked to recovery capital and positive well-being. So one of the questions that should follow is that, so is recovery housing available where it's actually needed most? Well, there's a recent national study of this found that among the counties that have, in this country, among the counties that have at least one recovery residence, substance use disorder mortality rates that were associated with alcohol or other drugs were not correlated with the density or the availability of recovery housing. So this really has service planning implications, because areas of higher overdose mortality should have appropriately resourced recovery housing. So the idea of using trauma-informed approaches is not new, and furthermore, these things they're in the literature, and people can be trained on how to use them. So, but one of the things that I wanted to highlight to you that maybe you haven't learned about before, this is a study that I helped co-author, and it was a question of, but specifically, what traumatic experiences are associated with drug use disorders in particular. And from this long list of traumas that were tested, I just put up here the ones that did have an association with drug use disorder. This might be things that people working with patients and clients can expect. For example, when it comes to many incidents, different types of physical violence, it was the ones that beaten up by somebody else, non-caregiver related, witnessing physical violence as well. And sometimes in dangerous neighborhoods, that is happening more often. So when it came to different types of sexual violence or victimization, rape was the one that was associated with the onset of drug use disorders. And then amongst the list of accidents and injuries that were tested, there was only one that emerged, and it's automobile accidents that were associated with the onset of a drug use disorder. And so the last thing I want to talk to you about is the idea of recovery-related discrimination. So what you're looking at here is kind of more ripped from the headlines type of things, analysis of state laws permitting intoxication exclusion. So alcohol exclusion policies refer to a set of policies that are used by insurance companies in many states to justify why they do not have to pay the bill for a patient who turns up when their injuries were related to alcohol or unprescribed drugs. So if alcohol or unprescribed drugs is in their system, they don't have to pay the bill. And this is devastating to the continuum of care when you think about different touch points, which might be the only touch points that people have an opportunity to get it navigated into a system. If a provider in an emergency department is scared to test for, does not want to test for alcohol or other drugs because they know that this is not supported in terms of reimbursement, that's then all of a sudden, so they don't test, they don't see a positive test come back, and they don't link them to the care services that could be. So it breaks up the systems that we rely upon. Drug convictions can send financial aid up in smoke. This was the only type of federal conviction that you could lose your financial aid for if you were a student. And this is why I call this discrimination, because you could have committed murder or embezzlement and still retained your eligibility for financial aid. It was really just the drug convictions that were related to losing your financial aid. And now, at the time we wrote this study several years ago, that was the case. Very recently, probably less than a year ago, there has been a change where Congress lifted a decades-long ban on student financial aid for those who have drug convictions. So that's good news. It shows progress, right? And it shows that our efforts can count, and they do matter. So, but we're going to take a look at the next thing here. More states lift welfare restrictions for drug felons, no more double punishment. This was the same idea. This was a policy targeting drug convictions, but the logic behind it was flimsy in that it wasn't appearing to be applied to any other conviction. It was really just this one type, and it was a lifelong ban on nutritional assistance, a lifelong ban on housing. And so we use this as a backdrop to inform part of a battery of a survey that we did that we called the National Recovery Study. So it was really informed by the idea that we know that these discriminations exist, that they were legal, and that they were ongoing. But the question was, to what degree is it affecting people after they resolve a problem with alcohol or other drugs? So we did a one-time cross-sectional survey that was nationally representative of people who resolved a problem with alcohol or other drugs. Thousands of people were involved in it. And for this part of the survey, we asked them, since resolving your problem with alcohol or other drugs, how frequently has the following occurred because somebody knew about your alcohol or drug history? They can be grouped into what we call micro-discriminations. These are the experiences that occur more as social interactions and exchanges like insults, but there's also the macro discriminations, more of what I just showed you, violations of rights that occur at the organizational or policy level. And what we found here is that if you take a look at the micro discriminations reported by people who have already resolved a problem with alcohol or other drugs, 48% saying people assumed I was likely to relapse, 35% people avoided me, 38% said that they felt like they were held to a higher standard because somebody knew about their alcohol or drug history. 36% saying they were treated less favorably because people knew about their alcohol or drug history, and people avoided me. People accused me of being dishonest, and of course rejected by family and friends. You can see more of that on that side. And then when it came to the macro discriminations, 18.5% reported being unfairly treated by the police because they felt like they knew about their history with alcohol or other drugs. Let's see, 15% said it was hard to get health insurance. 14% said that they lost their job because somebody learned about their alcohol or drug history. 11.6% denied a loan or didn't even bother to apply. The reason I put in there didn't even bother to apply is because many people are well aware that they've lost their rights to higher education when that was still going on. You can see that people were being denied housing, food assistance, the right to vote. Now that is not specific to drug convictions. There's a number of convictions that one can lose their right to vote. Insurance not covering some of their medical costs. These were things that we know were allowed to happen. And so we found that individuals who experienced this recovery-related discrimination, it was associated with more psychological distress, lower quality of life, and lower recovery capital after, which is another way of saying recovery resources that people have. So it matters. By the year 2055, there'll be no single racial or ethnic majority, so it's important for all of us, the scientists, practitioners, policymakers, to anticipate increasing diversity. We need to be reissuing building permits in terms of nutritional assistance, housing, voting, employment, like we did with financial aid. And these are the types of levers we can pull to reshape the landscape of recovery. We need to also change the narrative to how to focus on what our institutions are doing to magnify harm from disorder rather than minimize harm and promote well-being. So let's take a look at where we went to today. We started with racial literacy, talked about the effects of race that are really best interpreted as a caste system. When it comes to epidemiology, course of illness and recovery, individuals that identify as Black are more likely to have a delayed onset of the disorder, but a more chronic course of illness. I've shown you how they tend to be overly reliant, that the system has made over reliance on methadone compared to office-based treatments. for opioid use disorder. And that's very, that has a lot with race and class at the same time. And furthermore, the highest rates of overdose compared to white individuals over the age of 55 was Black males. You remember that line that was escalating, and that's what's going on right now. And then when it comes to recovery transformations, working in Black communities, go in leveraging peer-based services to try to combat medical mistrust. These Black communities want trauma-informed approaches to be integrated into things that are rolled out. And we also have a need to reduce recovery-related discrimination, which is affecting everybody. And it's not to say this is a comprehensive list, but it is a starting list for recovery transformation plans in Black communities. So I will stop right there.
Thanks, Corrie. That was fantastic. What a lovely overview and education there on many facets of this area. Do we have any questions, live questions? We've got time for live questions. We have about 20 minutes and discussion, or post questions in the chat. I don't know if we have any in the chat, Maya, do we?
No, not so far. No questions in the chat.
So any questions or comments?
Can I ask a question?
Yeah, Dr.
Hi,
Gross.
Corrie, Dr. Vilsaint, thank you for the talk. Just a quick question. So you talked about this discrepancy between treatment, maybe treatment and recovery support service, but certainly treatment seeking, showing this delay among, I don't know if it was Black individuals only or Black and other minority individuals. Yeah. Does anything come to mind in terms of things that we all as a community of researchers, clinicians, policymakers, so on and so forth should be thinking about in terms of doing a better job of engaging these folks earlier on in the process, especially thinking about this period of like young adulthood as being a prime opportunity to engage folks, because that's when problems are starting to develop. Any ideas, even if it's a sort of brainstorming, things that come to mind of ways that we could all be thinking about developing and testing to better engage these folks earlier on?
Sure, yeah. You know, I think about the utility of using the recovery support services and the way that they, one, can create independent pathways to recovery, but as well, they can also be ways that people end up linking to care sooner. So in particular, when I'm thinking about Black males, in particular younger Black males, the criminal justice system has had a huge impact. It's really worth an entire talk of itself about that being a primary factor. In fact, they estimate right now, in large cities, half of all African males are reporting some touch point with the criminal justice system along the way in our major cities. So treatment models are often not set up always to link with them, deal with them, but peers, I've spoken with a number of peers who've been able to work in models, very interesting models, where they are allowed to go into the criminal justice system and start laying out the recovery, they start laying out that recovery framework or that recovery orientation. And so, yes, mutual help meetings are going to be incredibly important. The science speaks for itself on that, but peers are going to provide, these types of recovery coaches and stuff that are allowed to go into the criminal justice system are going to provide different types of linkages. For example, they're telling me that when people are getting ready to come out of incarceration, this is they use this as an opportunity to direct people towards sober homes as opposed to halfway houses. And so they keep this recovery framework going for them. But the criminal justice system has had a huge impact on Black males, particularly that age group. And so I think about using them to have better access and better reach into these Black communities, which includes understanding that Black males are in criminal justice system.
Great, thank you. Yeah, it's really helpful. Thanks.
I see Anne has a question in the chat. Hi, Anne, by the way. She wanted to know about the recovery-related discrimination, if there was anything with race regarding that. So, Anne, yeah, thanks for asking, actually. So the data that we have on that that I have a citation for was actually specific to just the group that were in recovery from alcohol use problems. So that's why in my attempt to really honor the opioid use theme of the day, I didn't totally present that, but I would like to tell you that when we did an analysis to look at we saw recovery-related discrimination. And so the question, was it disproportionately affecting any minorities at all? It appeared that all of the recovery-related discrimination was affecting everybody the same, with the exception of one group, and that was individuals that identified as Black or African American when it came to race or ethnicity. More specifically, it was the structural effects. It was not the micro discriminations. There were no differences in the derogatory statements, insults, and things like that. There was a number of the questions, the items that we asked them, though, that were tied to housing. Housing came up, but a couple that were tied to employment. Black individuals were like 3 and 4 times as likely to say that they had a job but couldn't get a promotion, or that they could not get a job because somebody knew about their history with alcohol or other drugs. So that tells me about the importance about the role of employment in recovery, particularly for individuals that identify as Black. And there are programs that specifically work to support recovery, employment in recovery. Like I know at the Recovery Research Institute, right now we're doing an evaluation of a program called Access to Recovery. It's something that SAMHSA does, but these are the types of wraparound services that you can use and think about where you target them, understanding that African Americans are more likely to be affected. Their employment is more likely to be affected in recovery. And so these are the types of services that we can use. And the last thing I'll say about that is my colleague, David Eddy, he led a study regarding employment amongst people in recovery. And he found that there were 2 groups who were less likely to be employed in their recovery. It was individuals who had a history of criminal justice, and then individuals who identified as Black, which is really a disheartening finding. It kind of shows you when you're Black, you don't always have to do the crime to do the time. It affects you the same when it comes to your likelihood of being employed. So thank you for asking that, Anne.
Thank you very much.
Other questions or comments?
Yeah, so I'll chime in real quick. I have kind of a more of a comment, I think, than the question, but you're absolutely welcome to kind of engage with it and talk about it. But just kind of piggybacking on what Brandon was talking about, that, or Dr. Bergman, sorry, that, we have one program that I've seen that I haven't seen in person, but really piqued some interest of mine, is that Texas Tech, their collegiate recovery program, has an outreach where they actually go into the local jails and the local prisons as a recruitment tool to actually try and recruit individuals coming out of the prison system right into the Texas Tech Collegiate Recovery Program, kind of like a college and prison program to an actual college program. And so I guess my thought is, what are some things that we can do to create more of these kinds of programs? Because I think that would be just a huge step forward to kind of, I think the key to social elevation or to having a career a lot of times is this mobility that college enables people to have. And so if you could just talk a little bit about either programs like that or what we can potentially do to do those outreach programs so that we can reach those individuals.
Yeah, absolutely. Nice to see you again, Noel. So yeah, that's incredibly innovative, right? These collegiate recovery programs, in particular, the way that you're describing them being used, that's incredibly innovative. The problem is it is largely absent from our literature. It's absent from the things that we document as well. And so the literature on collegiate recovery programs is really sparse. And so we need more of that documentation happening by far, and the way that it's being used in this innovative way, and able to access high-risk populations who we know who we know actually have the highest risk of overdose when they're coming out. Those things need to be documented. First, just talking about feasibility and acceptability, and then eventually the research can start to build as we start to look at cross-sectional looks, and then even efficacy of linkages and efficacy of these things. But it has to kind of go through those phases of documentation so we can have something to disseminate. Policymakers need something to point to and say, here's how we know. And so we have to keep building up the literature on recovery and recovery support services the way we did so well for substance use disorder. Look what we have for epidemiology. Look what we have for treatment. That's a model of where we should be shooting to roll out our literature for recovery support services and recovery in general. So thank you.
Yeah, you're preaching to the choir on all of that. So thank you.
That's right. I know.
So there's a question in the chat that came in from Jessica. In your research, have you found how pharmacies can engage in dismantling racism with patients who are working with Black or brown individuals with opioid use disorder?
So speaking about the role of pharmacies and the use of medication, Noelle was just talking about working with incarcerated populations. This is some of the stories that are done. You have to go to a certified clinic to get methadone, right? It's highly regulated, as opposed to being able to get it at a pharmacy. That was something that they decided against. So pharmacies can absolutely be used to give better access to methadone. And some of the stories that were being documented in Baltimore is that they were using these pharmacies were engaging in supporting mobile health clinics to just sit right outside of some of the jails and prisons, just at the most popular times that people were released. And they just sit there. And they're able to catch people and start immediately, same day, linking them with services, linking them with medication, harm reduction services, initiation into recovery support services and stuff like that, just by waiting where they're at. When they know the most popular release times were. But stuff like that absolutely requires the support. It requires the support of being able to access those medications and kind of sometimes thinking about and loosening regulations about the historical way that we've allowed people to have access to methadone and things along that line. So.
Great. Here's another question. Thanks, Corrie. You're getting lots of praise here in the chat, by the way, about your excellent presentation. This is from Katie Wooten. She says, thank you for the excellent presentation. Have you seen differences in the use of treatment agreements with medications for opioid use disorder specifically, or for example, requiring urine drug screens?
I have not seen anything documented in the literature that showed that maybe African-American patients were more likely to be drug screened than others. That's a great research question. I haven't seen it. It doesn't mean that it's not out there necessarily, but I have not seen that. I've yet to see that. So that's a good question.
Other questions? Yeah, Javon?
I realized I did an applause instead of a hand raise. Also that well, John here. So first of all, Corrie, this is amazing. You are consistently, the work you're doing is always amazing to me, and I love it. One of the things I wanted to kind of highlight is also this aspect of like accessibility, right? And like who are they seeing? Like who are these individuals seeing, and where can we not catch them? But the idea being is, with a lot of the research I've been noticing, it's like our master's level clinicians, our social workers, like where are they coming through, and how do we readjust as psychologists, right? And like looking at about expanding how we integrate some of the research you're doing into our trainings and into the work that we're passing along to, baby psychologists as they're coming up, so that we can start to change like a lot of the understanding and rhetoric around what you're saying, because a lot of the things that you were sharing today are almost very significantly different from a lot of the rhetoric we're hearing, that I hear among the colleagues and such, without looking into the actual research and the implicit bias that comes into play of our understanding. I think the beginning of your talk was very clear around that, of like the impact of that implicit bias when looking at our own treatment and assessment and support to changing some of the recovery aspects of it. And I'm wondering if you're noticing any trends in regards to the professionals or providers that are being seen that are seeing these folks?
You know, there's going to be, when the DSM comes out, there's going to be an update of some sort coming out in a couple months that I was reading about. And there's going to be the introduction of a section on how racism has affected mental health. Okay, so that's one thing to look out for in upcoming, you know, regarding upcoming trainings regarding that stuff. You know, when it comes to like a clinical level, biases and things like that that have been documented, I mean, across, more broadly, just across psychiatry, they talk about kind of misdiagnosis, interpretations of symptoms and things along that line. When working with like Black patients, even some that have been seen, you know, when it comes to the literature on substance use disorder, things that are coming up are going to be things along the line of the expression of trauma, the expression of aggression in Black males that sometimes, if they might not have been a Black male, might have been expressed or documented more as trauma, but instead people are feeling it more along the lines of aggression if it's in Black males. And so there's some literature showing those types of things that are emerging in clinical biases and trying to get people to be able to see beyond those things. And understand the way that race might be affecting the things that they're looking at regarding that. So, but yeah, I was reading about the DSM things that'll be coming out, talking specifically about how racism is affecting mental health. So we'll see how well they talk about it. I don't know if it's going to be anything specific to SUD or just mental health in broad. I'm curious. So.
Thank you for the great questions. Here's probably the last one we have time for today. It's from our own Dr. Emily Hennessy. She says, wonderful talk. I'd be curious to hear about the female experience in recovery, particularly for Black mothers, as some research suggests a very complicated set of challenges and stigma for that population.
Yeah, absolutely. You know, I'm working with a couple of groups and committees right now who are specifically focused on Black women. You know, so there's a population of pregnant and parenting women, you know, and substance use disorder and recovery. You know, that's a whole area right there. And we're doing qualitative interviews, we're doing all these things. What is coming up over and over again is the issues of losing child custody. And it is just creating enormous barriers to people disclosing that they're struggling with opioid use disorder or otherwise, because of the threat of losing custody. So the thing is, we think about, so what do we know about that body of literature? Wow, okay, so if we think about just child custody issues and the way it's disproportionately affected Black individuals, has just been devastating. It has gotten better. So I think, you know, just generally speaking, like 20 years ago, they had, it was when it came to child custody issues, that department was dealing with 40% of Black mothers, but Black people only make up 13% of the population. So when 40% of your population of who you're taking child custody rights away from were African American, that was a huge problem. Now, more recently, in more recent years, I've seen that number go down to about 22 or 23%. So we're talking about the women who are having child custody issues and dealing with the state. That's at least starting to get more representative of where their levels are in the general population. And at this point in time, we do have the science, and one study in particular that found that violence in the home was no more likely. They were able to compare it amongst different populations controlling for socioeconomic status and things, and found that it was no more likely to occur. It took a long time to even get that, but of course that's the underlying logic of why Black women, pregnant parenting women, were more targeted by child custody. But when it comes to more specifically the addiction and treatment literature, that's the number one issue that's coming up, is having to help them navigate the system with the child protection and custody rights, is what we're hearing and what we're learning from them. They don't know what's expected from them. They feel like it's a blind system. They don't know what they can say, what they can trust. And so Davita Schiff is a great one to follow on that. And she's got more coming out on it. In fact, she works at Harvard Medical School. She's an MD, and she works with pregnant and parenting populations with opioid use disorder, Black women. And she's one of the only few that we have, honestly, working in that area. So.
Well, sadly, we have come to the end of time. Corrie, just thank you so much for this talk. Thank you. I know everybody's cheering you on here with your focus in this such an important area. So thank you for leading the charge and for doing such a fantastic job and providing us with all these insights and knowledge. Obviously, a lot to do here, and thank you for that. Thank you all for coming. On behalf of the Opioid Response Network and the Recovery Research Institute, thanks for coming. Join us next time, which will be in April, right, Maya, with our own Dr. Lauren Hoffman. Look forward to seeing you back then. And thanks again for attending today. And thank you very much, Corrie.
Thank you.
See you, everybody.
Bye.